I just want to say that I feel very privileged to have been included in the symposium. I want to applaud the organizers for what has been a very stimulating program to this point. So today I'm going to review what we know about the role of maternal weight gain in pregnancy, and nutrients as determinants of childhood obesity. And I want to thank Dr. Liu for setting the groundwork here. And you'll see that there's going to be some reinforcements of some of the messages. To start, let's review what's happening on this slide, which is estimates of obesity in the US. As you can see, in 1985, there were incomplete data noted by the white states. But based on the states that were assessed, obesity ranged between 10 and 14%. Jump ahead 12 years, and all states had estimated obesity, which was increasing with most states between 10 to 19%, but a few states led the way with a rate of 20 to 24%. 13 years later, in 2010, many states had rates of 24 to 29%, and in the Southeast, we were at or exceeded 30% obesity. Note here in the lower left-hand corner that there is a trend for increasing body weight for both men and women between 1960 and 2000, with an exaggeration in the two decades, 1980 to 2000. So in summary, as a population, we are more overweight and obese than we were 2 decades ago. And this is due in part because we are starting out heavier. That is, our babies are being born bigger and heavier. They are already on the slippery slope as they enter this world. At universities and research institutions in the SEC, we are working to reverse the trend. We want to see a different map. We are working to change or modify those factors that can affect infant growth and development before birth and in the first critical years of life, as pointed out by Dr. Liu. So many of us are studying pregnant women to determine if there are dietary interventions to complement the physical activity interventions to reverse the trend that we witness here on this slide. You all know about the National School Lunch Initiative. And I mention this because with respect to obesity, clearly no one has the magic formula. It took years to get here, and we're not going to turn it around on a dime. Efforts are needed at all levels, but pregnancy seems to be central to the situation. It's clearly documented that women are coming into pregnancy with higher than ever body weights. Estimates from the CDC, shown here on this slide, put obesity, defined as having excess body weight, body fat, at 1 in 4 pregnant women in the US, over 41%, or 41% higher than the previous decade. And this is obesity, not just overweight. The data here emphasize that obesity among young girls in the US has increased in the groups that are shown on the slide. One of the reasons I include these data is that in this age range, we have young girls and women who are approaching or are in the reproductive phase of their life cycles. This means that interventions need to start early. Interventions need to start early. We need to be targeting young women in this age range with the education messages and interventions. Regarding pregnancy and weight gain, there are 2 critical points for interventions. First, women are gaining more weight during pregnancy than is recommended. And you may ask, recommended by whom? And these are the expert clinicians who are working with pregnant women and women of childbearing ages on a daily basis. Secondly, women are not losing the extra weight after pregnancy, and thus they enter the next pregnancy even higher. Why the concern about excess weight for the woman who becomes pregnant? The following slide answers the question, and I'm going to guide you through it. So this figure helps to demonstrate our understanding of what is occurring and contributing to our current obesity statistics. In cycle A, in the upper right-hand quadrant, when women are too heavy before they become pregnant and then go on to gain too much weight in pregnancy, the result is that their babies are larger and bigger. And if they do not lose that extra weight, they then go on into the next pregnancy even heavier. Turning attention to cycle 2 shown on the figure, here we have a baby that is already heavy and bigger, having been born to an overweight woman. Then, depending on feeding practices immediately following birth, the baby gains too much weight too fast. And again, re-emphasizing the point made by Dr. Liu, today it is well established that breastfeeding can prevent this fast weight gain. Then there is the question about when solid foods are introduced, early versus later. The cycle is completed with the next generation too heavy for their pregnancies. So now we have a second generation of overweight moms. The cycle just repeats itself. Intervention is clearly needed. So to summarize to this point, entering pregnancy with excess weight is a major factor that predisposes the infant for overweight or obesity later in life. What we are seeing is that the cycle is being repeated generation to generation. When women have not attained ideal body weight before going into pregnancy, there are recommendations for optimal weight gain in the pregnancy. And this table you have seen in a little different form just moments ago, and it summarizes the recommendations for weight gain in pregnancy according to body weight. You can see that overweight and obese women are recommended to gain much less weight than normal weight women, and the recommendations for weight gain in the second and third trimesters is about a half pound or less per week. The optimal rate of weight gain is minimal for these women. So what we would like to see is that a woman would achieve her ideal body weight. We're looking at the normal range. And then there would be more flexibility in weight gain, as shown here for the normal weight woman, where their total weight gain is 25 to 35 total pounds compared to the obese woman, which is 11 to 20 pounds. And the weight gain in the second and third trimesters is more liberal. Summarizing again, women should strive for normal body weight before pregnancy and adhere to weight gain recommendations during pregnancy. So here I have what we would refer to as foods to be included in a balanced diet for pregnancy. There is, within each group, there is variety within the food groups that tends to provide the nutrients needed for pregnancy. And what I'm going to do is focus on the helpful fats, and specifically on the omega-3 fatty acids that are of particular interest with respect to pregnancy and pregnancy outcome, especially infant development and growth. So, most folks have heard the term omega-3 fatty acids, and many food products today are labeled to contain them. The term fatty acids refers to the fat that makes up the bulk of the fat in our diets, with the omega-3 fatty acids present in much lower concentrations or amounts than some other fatty acids. So I want to see a show of hands. How many of you look for products that are labeled with omega-3 fatty acids when you shop. Okay? Don't be shy. You may or may not know that all omega-3 fatty acids are not the same. For package labeling purposes, you may see either DHA, docosahexaenoic acid, or EPA, icosapentaenoic acid, noted, which is why we refer to them as DHA and EPA. And these are long-chain omega-3 fatty acids, but because they have different names, you can guess that they are not the same, and they have different roles in the body. For instance, DHA is laid down preferentially in the brain and in other nervous tissues of the body. So this slide summarizes some of the work that we have conducted looking at intervention in pregnant women with docosahexaenoic acid. And what we set out to do was to supplement in a randomized placebo-controlled trial in pregnant women from the middle of pregnancy until the birth of their infants with docosahexaenoic acid in a cereal-based food bar that the women consumed. So we gave, they were provided. So in brief, to summarize what we found over time. So we were supplementing with omega-3 DHA specifically, and right after birth, we assessed sleep in the infants. Okay? So sleep is one of the, or how an infant sleeps depends on maturity of the central nervous system. And so we assessed sleep in days 1 and 2, and what we found was that the sleep in infants of the mothers who were born, who consumed DHA during pregnancy, they had better sleep at 1 and 2 days after birth. We also know that DHA is important to eye health, and perhaps some of you have been prescribed supplements with DHA for eye health, such as warding off macular degeneration. In our study with pregnancy and infant outcomes, so let me come to the eyes. So at 4 months, these infants had better vision, and when you look at vision in an infant, you use an appropriate assessment for an infant. And the assessment that we use is similar to the examination you may get when you go to the eye doctor, and he or she asks you to look at the chart across the room, the chart hanging on the wall, and tell him or her the smallest letters that you can discern. And in our study, the infants who were born to mothers without the supplementation could see the letters that are larger, whereas the infants born to women who were consuming the DHA, those infants could see the smaller letters. So the test that we gave them was comparable to that adult test. So at 9 months of age, our babies had a better ability to solve some simple problems. We refer to them as baby problems, such as how to retrieve an out-of-reach toy that's lying on a blanket that he could reach. And in our assessment, what we found was that the infants whose mothers were consuming DHA had better problem-solving ability. Especially germane to the topic of obesity today is that infants born to women who consumed the omega-3s during pregnancy were leaner at birth than infants of the mothers who did not consume the DHA. And the thought is that the omega-3 fatty acids affect the ways fats are handled by the body, resulting in less fat tissue being deposited. And there was some discussion about how this might occur yesterday. Dr. Voy gave a very nice presentation. So it appears that in some way, perhaps by affecting the PPAR, through PPAR alpha, the omega-3s decrease fat tissue that's being deposited. So today, some prenatal vitamins contain omega-3 fatty acids, and infant formula in the US is fortified with DHA. But where do we find these helpful fatty acids? As adults, we're not eating formula or fortified baby foods. Most of us in this room are not taking prenatal vitamins fortified with omega-3 fatty acids. So the dietary source for most of us is cold water marine fish. And the reason why these fish are good sources of omega-3s is that they eat algae that have the machinery or the enzymes to make them. In this way, we are very much like fish because we don't have those enzymes either. And while fish eat algae, we can eat fish. And you have a picture of the food chain. So as a result of evidence coming from different laboratories around the planet, the U.S. Department of Agriculture's Dietary Guidelines for Americans in 2010 included for the first time the recommendation that pregnant women and women of childbearing ages, including adolescent girls, include cold water marine fish in their diets on a weekly basis. And this chart just gives you some idea of some of the fish that are very good sources of DHA compared to other foods like poultry. So in closing, I emphasize that meeting the challenge of reversing the epidemic of childhood obesity starts with the pregnant woman, and it includes approaches that change the factors that can be modified. Pre-pregnancy weight, weight gain during pregnancy, and the inclusion of many nutrients known to be important to pregnancy outcome, with attention to the docosahexaenoic acid or omega-3 fatty acids. Thank you.
Questions? I think we have several over there.
Hi, thank you for that vivid picture you painted of the cyclical women who gain too much weight, who have babies that may weigh too much, who become women who gain too much weight during pregnancy, and on and on and on. But something I might have missed in your introduction of that, would you say that those intergenerational cycles are distributed equally across income strata in our society, or do they tend to cluster in a particular part of the socioeconomic spectrum?
So I haven't shown data. I think most of us have probably seen some of this data in our readings, and I don't have references to give you, but I'm going to say yes, that they tend to cluster in some of the lower economic groups.
So poverty is kind of a comorbidity here.
Pardon me?
I mean, poverty is essentially a comorbidity here.
Mm-hmm. So
does that open other doors for intervention? Should we be really thinking about, living wage laws and this sort of thing as much as we should be thinking about DHA?
Well, I'm not just talking about DHA, though. I'm talking about moderating weight gain before pregnancy and during pregnancy. So I think we have a lot of work to do in terms of educating, and I think the education has to start with very young girls,
right? But
approaching adulthood here.
I guess Dr. Lauer got me started thinking about sometimes we're not looking at the real toxins, and it seems to me that in this case poverty might be a real toxin. That's all I'm saying. Just wondered if you thought that as well.
I'm sorry,
Do you think that as well? Do you think poverty could in fact be a toxin when it comes to perpetuating these women who gain too much weight?
Well, I think when you look at poverty, you're looking at populations that have so many issues in their lives that how they are going to eat or specific foods they're going to eat is just one sector of it. Many of them are wondering how they're going to put any food on the table, but we have to do something about helping them make wise food choices. And if we come back to DHA, a can of light tuna is a very affordable source of DHA, good protein, and it's one of the cheapest proteins probably that you can come up with. So we have to do a better job of being out there and educating and showing them how they can do it and why they should want to do it.
Kristen Platt, University of Kentucky. I was curious in your DHA supplementation study if you would have predicted different outcomes if the supplement had been given in the first half of pregnancy.
Would we have predicted different outcomes? I wouldn't have predicted different outcomes. No, we had significant, robust differences between the groups. So if you've seen it from the middle of pregnancy to the end of pregnancy, they should have still been there. Yes, would you agree?
Good morning, Brittany Lockard from Texas A&M University. Thank you so much for that information. My question was in regards to, were you able to, in your research, tease out with these baby problems or even the vision that you researched in the infants, were you able to tease out differences between if the mother had supplemented with DHA versus once the infant was born, whether they were supplemented through formula or, I presume, breast milk, you still continue to receive DHA at that point. Can you actually draw some differences between?
That's a really good question, because as it turned out in this research, as we were embarking and getting on the study, really getting it going, infant formulas came out with DHA in them. And we were left with the question of what do we do, how do we handle it, do we do the study? And so what we did was we knew how the infants were being fed. We had 5 different categories. Were they being breastfed? Were they being formula fed? Was it formula with DHA? Were they being fed both formula and DHA? So we used those, we controlled for all of those factors in the analyses. And frankly, that's what we did and the best we could do. But we were looking at it and we said, do we give money back to the funding agency?
Are they able to, after birth, can you catch up? If you catch them young in life and supplement DHA, can they catch up on some of the neurological?
Well, the thing is that in utero, and the sleep studies really told us that, because the sleep studies that we conducted are dependent on maturity of the central nervous system. So there's clearly a lot going on in the last half of pregnancy that requires DHA. Can they catch up? There are other studies that's a good question, that have tried to look at that. It's not always easy to find out what's going on, but with some of these studies, I think there is catch-up. There is catch-up, because when you make assessments at different times, you can catch that. And we saw that, actually, with some of the assessment.